Welcome to the first part of the training module on neonatal resuscitation. In this module, we will briefly discuss why neonatal resuscitation is so important. Then we will learn what preparations should be done whenever a birth is anticipated. We will describe how every newborn is assessed at birth, how to identify which newborns need resuscitation, and learn various steps in the process of basic newborn resuscitation. So why is it important to learn newborn resuscitation? Well, birth asphyxia is a big problem. First of all, it is one of the top 3 newborn killer causes. But that is just the visible part of the problem. Even more important are the hidden parts of the problem like stillbirths and lifelong neurological damage. But the interesting part in this case is that the solution to such a big problem is actually really simple. All we have to do is to just ensure that every newborn gets its first breath in the first minute of life. And how can we ensure that? By ensuring that every person attending a delivery is trained in basic newborn resuscitation. It is absolutely crucial that anybody who is even remotely likely to be a birth attendant is trained in at least basic newborn resuscitation. So before going to the specifics, let us first understand the overall flow of the newborn resuscitation, which is a very orderly and systematic process. The birth attendant or the newborn care provider must be prepared to perform resuscitation if need arises. It is recommended that the newborn should be delivered on mother's abdomen. This early initiation of skin-to-skin contact goes a very long way in ensuring a smooth transition of the fetus into the neonatal period. Immediately after birth, the newborn should be assessed for any need of resuscitation. Most newborns will turn out to be breathing well and they will not require any resuscitation. For all such newborns, the clamping of umbilical cord should be delayed for more than 1 minute. These babies will just need routine newborn care while being with mother. Now, few newborns will have some problem in breathing and they will need assistance in form of initial steps of resuscitation. Even lesser proportion will require positive pressure ventilation. These steps will be covered in part 1. Very few newborns will not respond to these basic steps and they will need further advanced steps of resuscitation like intubation, chest compressions and medications. We will cover these in the part 2. So two things we need to remember in this flowchart. First, it is very important to maintain temperature of the newborn throughout the resuscitation process. And secondly, as we discussed earlier, every baby must receive its first breath within the first golden minute of life. The first and probably the most crucial step in any resuscitation is being properly prepared. As they say that if your preparation is good, half your task is already done. The preparation for birth starts with assessing the risk factors which can help in predicting the babies at risk. 4 key questions should be asked from the obstetric provider. 1. What the expected gestational age is. 2. Whether amniotic fluid is clear or meconium stained. 3. Whether single or multiple babies are expected. And 4. Whether any other obstetric, antenatal, intranatal risk factors are present. Now this is followed by assembling of resuscitation team based on the risk assessment. Roles and responsibilities should be allotted to each member by the team leader and everyone should be briefed about the anticipated problems and the backup plan. Next, the room and the neonatal corner needs to be prepared to receive the newborn. This includes closing down of all windows, ACs, fans, ensuring that the room is warm, radiant warm is switched on, and the mother and obstetrician is informed about delivering the baby on mother's abdomen. The whole team should perform hand washing and use appropriate personal protection equipment. A standard delivery room checklist should be used to ensure that all the necessary equipments and supplies are assembled and that they are functioning. Especially the positive pressure ventilation device, suction equipment, stethoscope, laryngoscope, etc. should be checked for optimal functioning. Now that we have assembled and checked everything, now we are ready to receive a newborn. Now, presently it is recommended that every newborn must be delivered on mother's abdomen to facilitate early skin-to-skin contact. In addition to keeping the babies warm, this also helps early establishment of breastfeeding, allows delayed cord clamping, helps in placental expulsion, prevents postpartum hemorrhage, and ensures a smooth fetal to neonatal transition. So you can see there are so many benefits from this simple action of delayed cord clamping. As soon as the baby is delivered on abdomen and the time is noted, every newborn needs to be assessed for the need of resuscitation. This assessment is done using three questions. Is the baby crying or breathing? Is the baby term? And is there good muscle tone? Now, if the answer to all these three questions is yes, which will be the case in most newborns, then such newborn needs no resuscitation and only routine care steps are needed. What are these routine care steps? For such vigorously crying newborn, routine care includes continuing the skin to skin contact with the mother to keep it warm, positioning and suctioning only if necessary, drying the newborn and removing wet linen, covering with a warm sheet, putting a cap on the head, identity tag, delayed cord clamping and cutting delayed by more than 60 seconds, initiating breastfeeding and ongoing monitoring. Now, in some 10 to 20% of newborns, depending on the profile of your healthcare facility, the answer to any of these three assessment questions could be a no. It is very essential at such time not to panic and follow a systematic, orderly algorithm of resuscitation. Such babies will need what are called as initial steps of resuscitation. These may be done on mother's abdomen if the team is comfortable, else the umbilical cord may be clamped and cut. The obstetrician and mother should be briefed and the baby transferred to the radiant warmer for the initial steps of resuscitation. We will now see a brief video demonstration of these initial steps.
In radiant warmer, we do the initial steps. Now, first thing is providing warmth. So radiant warmer is on, so the baby is not at the risk of getting cold. Now, the first important initial step is positioning of the head. So we have to position the head in a position that is slightly extended neck. It should not be too much of hyperextension. It should not be too much of flexion. It should be slightly extended neck, which is called a sniffing position. You can roughly know that the position is good when the external auditory meatus is in line with the anterior shoulder, or there are various other ways also. When the tip of the nose is the topmost position, you know that the baby is slightly extended. Sometimes if the head is too large because of caput or big head, then you might need shoulder roll to keep the position in slightly extended. Otherwise, it is not a must. Second important initial step is suctioning. Now, suction will be done only if it is needed. So, if you find that there is meconium stained liquor, or if there are a lot of copious secretions, or there are visible obstruction to the respiration, you need to do suctioning. Suctioning can be done by two things. One thing is suctioning should be done for mouth first, followed by both the nostrils. So this is suction catheter. You have to ensure that the suction machine is set at 100 centimeters of water or millimeter of mercury. Otherwise, if there is no electricity, then you can also use this mucus extractor, where one end of the mucus extractor will be used to suck out the mucus, and the second end will be in your mouth. The suction has to be done from mouth first, followed by nose. After this, we will do drying of the baby. Drying needs to be done thoroughly of all the body parts. The body needs to be dried nicely, including the back. After this, remove the wet linen and use another dry sheet. The next initial step is stimulation. We will stimulate the baby by using 1 or 2 back rubs, and after this again reposition the head. That concludes initial steps of resuscitation.
So just to recap, as shown in the video, the initial steps of resuscitation consists of keeping the baby warm, positioning, suctioning only if needed, drying and removing the wet linen, stimulating and repositioning the head. Now remember that though they have been shown in a sequence for demonstration, most often these will be happening simultaneously. So you will be drying and stimulating and repositioning the baby almost simultaneously. So after the initial steps of resuscitation have been performed, now the newborn needs to be reassessed by evaluating its respiration and heart rate. The heart rate must be auscultated using a stethoscope, as umbilical cord palpation is less accurate and may underestimate bradycardia. So you have checked heart rate and respiration, and if there is no gasping or apnea or heart rate is above 100 per minute, then look for two more problems: labored breathing and central cyanosis. If central cyanosis is seen, quickly attach a pulse oximeter probe to the right hand. If the preductal saturation thus obtained is less than the age appropriate targets despite regular spontaneous breathing and normal heart rate, then free flow oxygen should be provided. We will learn about oxygen in a separate slide after a while. If labored breathing is noted, check and correct head position, perform suction if needed, and consider continuous positive airway pressure or CPAP. On the other hand, if there is no labored or central cyanosis, the newborn should be provided what is called as observational care. What is that? It consists of continuing skin to skin contact with the mother to keep the baby warm, covering with a warm sheet, putting a head cap, initiating breastfeeding, and close observation for any danger signs. Now, on the contrary, after initial steps of resuscitation have been performed and you assess respiration and heart rate, at that time, if there is apnea or gasping or heart rate is below 100 per minute, that is the time when we must start quickly positive pressure ventilation and a pulse oximeter should be attached there. We will see all these steps in a brief video demonstration on positive pressure ventilation in the next segment.
When we decide to start positive pressure ventilation to a baby, there are three things. One thing is that we need to choose the right size of mask. Good size of mask will be one which covers chin, mouth and nose but not eyes. Okay, so this will be a small size mask for this baby. Second thing is positioning. So I have positioned myself at the head end of the baby and I am positioning the baby's head in sniffing position. Third thing is, if we need, we can also go for suctioning to facilitate positive pressure ventilation. Another thing is, when we start positive pressure ventilation, this is the time when we need to bring the second team member into picture or the assistant into picture. So can you attach pulse oximeter probe to the right hand of this baby? Also start auscultating this baby's heart rate and indicate the heart rate with your finger tap. Now while ventilating, we need to take care that we don't press the rim of the mask, otherwise it will deform and create a bad seal. So hold the mask from this side, the base of the mask. With these two fingers, you create a C to hold the mask and press it on the face. With these three fingers, you create an E which will again reposition the head into sniffing position. I start ventilating at the rate of 40 to 60 breaths per minute. To achieve this rate, the mantra that is advised is breath 2 3, breath 2 3, breath 2 3. Okay, so breath 2 3, breath 2 3, breath 2 3, breath 2 3, breath 2 3.
15 seconds over.
Okay, is the heart rate rising?
No, it's the same.
Okay, so heart rate is not rising. Now we need to look at the chest rise. Is the chest rising?
No.
So if the chest is also not rising, that means this is ineffective ventilation. So we need to take ventilation corrective steps. Ventilation corrective steps are MRSOPA. M means mask readjustment. R means repositioning of the head. So I have done these two steps and now I am again ventilating. Breath 2 3, breath 2 3, breath 2 3. Is the chest rising?
No.
Now we need to do S and O. For S we need suction. So I have suction, mouth as well as nose, and O means open the mouth and again reventilate. So with open mouth, I will do ventilation. Breath 2 3, breath 2 3, breath 2 3. Is the chest rising?
No.
So next thing is P. So we increase the pressure. Breath 2 3, breath 2 3, breath 2 3. Is the chest rising?
Yes.
Okay, so now we have achieved an effective ventilation. Now we will ventilate for 30 seconds. Breath 2 3, breath 2 3, breath 2 3, breath 2 3, breath 2 3,
13
breath
seconds
2
over.
3. Okay, is the baby breathing?
Yes.
So if this is baby is breathing, then we can taper the ventilation. Breath 2 3, breath 2 3 4, breath 2 3 4 5, breath 2 3 4 5 6. Breath 2 3 4 5 6 7, breath 2 3 4 5 6 7 8, and slowly I will taper the ventilation and look at the baby's breathing. Now this baby seems to be breathing well at around 40 breaths per minute. What is the heart rate?
140.
Okay. What is the pulse oximeter reading?
It's 80% saturation.
Okay, so the baby is around 3 minutes old. At 3 minutes, we need around 70 to 75% of SpO2. So this baby's oxygen saturation is good. This baby can go for observational care. I will cap this baby. I will put an identity tag, cover the baby in a warm sheet and give to the mother to keep between breasts. and tell the mother to start breastfeeding, but monitor this baby because it required positive pressure ventilation for some time.
So as shown in the video, we completed 30 seconds of effective ventilation that moved the chest. Now we again need to reassess the heart rate. At this time, if the heart rate is 100 per minute or more, ventilation should be continued until spontaneous breathing efforts reappear, and then positive pressure ventilation can be slowly tapered down. If the heart rate is between 60 to 90, 99, reassess ventilation, and if necessary, take ventilation corrective steps that were shown in the video, that is MRSOP or Mr. SOPA. But if the heart rate is less than 60 per minute, this baby needs further advanced steps. But before that, we must ensure that all the previous steps have been done properly. So quickly reassess ventilation, take ventilation corrective steps if needed. If there is still no improvement, the newborn must be intubated, oxygen should be increased to 100% oxygen, and chest compression should be added to positive pressure ventilation. These advanced steps will be covered in part 2 of this lecture. So friends, till now we saw how a newborn is assessed after birth, how and to which babies routine care is provided, and how initial steps and positive pressure ventilation are performed. Now before signing off, let us briefly understand at which stage in this resuscitation algorithm oxygen should be given. Well, we all must remember that oxygen is a drug and has its own side effects like any other drug. Hence, oxygen must be used very judiciously when it is required, but should never be used indiscriminately. Oxygen can be used in two ways during the resuscitation. One could be giving free flow oxygen. Second way could be administering oxygen during positive pressure ventilation. So let us look at them one by one. Free flow oxygen is indicated whenever a spontaneously breathing newborn with good heart rate, that is more than 100, has preductal SpO2 below these age appropriate targets given for term and preterm babies. So you can see here on the screen the targets of SpO2 for term and preterm babies for different times. Now at any time of life, if the SpO2 is less than these targets, then that baby needs oxygen. So these charts should be actually pasted on the walls of delivery room to guide the need for oxygen therapy. The crucial learning point here is that we neither expect nor want a newborn's SpO2 more than 95%. For example, a newborn with SpO2 of 75% at 2 minutes of life may look centrally cyanosed to naked eyes, but it will still not need oxygen because the age appropriate target for 2 minutes of life is 65% to 70%. Whenever indicated, free flow oxygen can be given using various methods that are depicted here, either a simple mask or oxygen tubing or a loosely held mask of either flow inflating bag or T-piece resuscitator. Oxygen can be titrated and stopped as the pulse oximetry targets are achieved. Persistent central cyanosis may need a trial of positive pressure ventilation. So that was all about free flow oxygen. Now another possible use, as I said, of oxygen could be oxygen being given during positive pressure ventilation. So what are the recommendations? Remember that while starting the PPV, oxygen is not needed for term babies. So for all term babies, start PPV with room air. For preterm babies, start with slightly higher, that is recommended is 21 to 30% of oxygen. Thereafter, it is very simple. Just titrate the oxygen therapy either up or down to reach the preductal SpO2 targets, age appropriate targets. However, remember that whenever chest compressions are needed, oxygen should be increased to 100%. So friends, what are the take-home messages? Every newborn must receive its first breath in the first minute of life. So we have to ensure to pick up those babies who are not breathing on their own and provide the first breath within the golden minute of life. Preparation for birth is very crucial and includes focused history taking. We saw those 4 questions. Assembling the team, preparation of room and newborn corner, preparation of equipments. Neonatal resuscitation is a systematic sequential process addressing temperature, airway, breathing, circulation and drugs, that is TABCD, in an orderly fashion. Delivering on mother's abdomen helps establishing early skin to skin contact and thereby maintains temperature, establishes breastfeeding and decreases postpartum hemorrhage and hence must be practiced. The current recommendation is delaying the cord clamping by at least 60 seconds in all crying or breathing babies that don't need resuscitation. Meconium, remember, does not change the resuscitation algorithm. Intratracheal suctioning is not recommended right now. Pulse oximeter should be attached as soon as PPV starts, and PPV should be started on room air in terms and 21 to 30% oxygen in preterm. And thereafter it is very simple. Oxygen should be just carefully titrated to age appropriate SpO2 targets. Achieving effective ventilation is the most important aspect of neonatal resuscitation, and it's absolutely crucial to understand and achieve good team dynamics. Thank you so much.